My guest is a true heart-centered leader and innovator and is having a big positive impact on communities that she serves. And she shows up in our conversation willing to be vulnerable and share the real bumps and detours and uncertain moments of her journey to where she is today. You're listening to the PHEC podcast, episode 404. The field of public health is so broad, overlapping multiple industries. With epidemiology at the core of public health, there are an unlimited number of ways to target specific populations, health conditions, environmental issues, and causes that matter most to you. My name is Dr. Huntley, and I'm the host here on the Public Health Epidemiology Conversations podcast. I'm an epidemiologist, consultant, and entrepreneur with over 20 years of experience in healthcare and public health. On this podcast, my guests and I engage in conversations that demonstrate the importance of public health and epidemiology across a variety of industries, helping you think outside the box and inspire greater positive impact in communities around the world. Now, let's dive into the topic of this brand new episode. Greetings, everyone, and thank you for joining me on this episode. I'm so excited to introduce my guest to you today. This is going to be a powerful conversation. And yes, if you've been listening for a while, you know I get excited about every single guest every time on every episode, but I deliver. It's always a great conversation. If you're new, let me introduce myself. My name is Dr. Charlotte Huntley. I lead an epidemiology consulting firm that supports large nonprofit organizations and government agencies. We specialize in a variety of community assessments. So we help our clients collect, analyze, manage, and communicate their data and health information in plain language to the communities that they serve. Please reach out to us through our website, which is drchuntley.com. And we'd be happy to meet with you and explore how we might be able to help support your organization. We'll also provide links to reach us in the show notes. Now, again, I'm excited to introduce you to my guest. Many of you may already know who she is, but I want to take a moment and formally introduce her to you, and then I'll connect our conversation. Dr. Michelle Taylor received her undergraduate degree from Howard University in 1997, her medical degree from East Tennessee State University, a School of Medicine, in 2002. She completed her pediatric residency at East Tennessee State University, Johnson City Medical Center, and the University of Tennessee Health Science Center from 2002 to 2005, and earned her master's degree in epidemiology from the University of Tennessee Health Science Center in 2009. As a C. Silva and Eddie C. Brown Community Health Scholar, she received her doctorate in public health from Johns Hopkins University Bloomberg School of Public Health in 2015. In 2018, Dr. Taylor completed her master's degree in public administration at the Harvard Kennedy School of Government as a Commonwealth Fund Mongan Fellow in Minority Health Policy. From 2014 to 2016, Dr. Taylor, a pediatrician, was Associate Medical Director and Deputy Administrator for Maternal and Child Health at the Shelby County Health Department in Memphis, Tennessee. Dr. Taylor is also a colonel and residency-trained flight surgeon in the Tennessee Air National Guard. Before returning to Memphis, Dr. Taylor served on active duty for operational support and statutory tours as the Credentialing and Privileging Branch Chief and the Division Chief for Aerospace Medicine in the Office of the Air National Guard Surgeon General from 2019 to 2021. Since 2021, Dr. Taylor has served as the Division Director for Health Services for Shelby County Government in Memphis, Tennessee. In this role, Dr. Taylor leads the team that plans, organizes, and maintains public health programs and services for Shelby County. To that end, she leads the operation of Shelby County Health Department, which is responsible for the delivery of all public health services and enforcement of applicable health codes and ordinances of Shelby County and applicable statutes and regulations of the Tennessee Department of Health. Dr. Taylor has 2 children, Malik and Ella, and she loves traveling to new places, baking, walking, and reading. Let's connect my conversation with Dr. Taylor right now. Well, hello, Dr. Taylor. How are you?
I'm wonderful. How are you?
I'm doing well. I'm so happy that we finally got our schedules together and are able to have this conversation.
Absolutely. It's amazing because with everything going on, I didn't know if it was going to happen. So this is perfect.
Yes, yes, I appreciate that. We were chatting just a little bit before I hit record, doing a little bit of check in. And I really do appreciate you making some time for the conversation. We bumped into each other at a few conferences, and the last
Yes,
time around, it was like, let's just make this happen. And
that's right. That's exactly right.
I love that. So let's start right at the top. This is one of my favorite things to do is hosting these episodes and getting to know my guests. So why don't you introduce yourself and just tell everyone a little bit about who you are and what you do? Maybe throw in a fun fact in there.
Oh, sure. So, hi, everyone. I am Dr. Michelle Taylor. I'm the Director and Health Officer at the Shelby County Health Department in Memphis, Tennessee. I am a native Memphian. That's how you say it. I was raised here, and it's been the privilege of a lifetime to serve as the health director here in the county. I would say a fun fact about me. Let's see. Well, I always like to tell this one. In addition to being health director, I'm also a flight doctor in the Tennessee Air National Guard. I have served for just about 15 years. And as part of my training as a flight doctor, I had to go to what we call flight surgeon school. And I had to learn how to fly a small plane. Now, here's the deal. I never learned how to land and I never learned how to take off. I just couldn't get the rhythm of it. But I can keep a plane in the air. I can do that as part of my training. And the reason the military does that is because they want us to feel how task saturated pilots and aircrew are when they are flying, so that if they come into the clinic and complain about something specific, we know what kind of movements and what kind of thought pattern they've had to go through to get that plane to do what they wanted to do.
I gotcha. That sounds exciting, but also nerve wracking at the same time.
Yes, that is the perfect description for it. But I had an excellent flight instructor because every student that goes through has their own flight instructor that goes up with us. We do different types of work in the plane. It's quite the process. And he made it fun after me being very nervous at the beginning because he told me, he said, I bet you're the type that jumps at every bump when you're on your commercial flight going wherever you're going. And I said, yeah, I actually am that person. And he said, okay, by the time we finish, you will not be that person anymore. And he was right. I mean, learning about aviation in relation to medicine really did help me a great deal. And I love it clearly because I'm still serving. So,
Well, that was truly an interesting fun fact because I did not. Plus, I can't imagine you being a nervous person, though. You always seem
well,
really
I
cool,
try not to
calm.
show it, right? So I'm very good at hiding it. But there are some things that can bring it out. Yes.
Yeah. Gotcha. Oh my goodness. Well, this is wonderful. One of my favorite questions to ask helps me to kind of get to know your journey. I'm really always fascinated to hear how people get into public health, especially someone like you who has a medical degree and a public health degree bridging together. So, when did you first learn about or become interested in public health?
So, I mean, in hindsight, I can tell you that I learned about it before I knew it was public health. My mentor here in Memphis, Dr. William Terrell, I actually got connected with him through a medical school, law school pipeline program through the University of Tennessee. And so he was my mentor the summer before I left to go to undergraduate school at Howard University. And he was, and still is, a pediatrician here in the city and was very focused on not only introducing me and another doc who's still a pediatrician to the practice of medicine, but also very much engaged in teaching us the practice of community health. So a lot of times I tell people, like when we worked with Dr. Terrell, we didn't just shadow him and go into rooms and see patients. Before he even let us get to that point, we had to learn how to sit at the front desk and take calls and check in patients. We had to work in the billing office. We had to do what the medical assistants did and weigh patients. We had to work in the lab and learn how to do blood draws and all of that. He made us learn every step of the process for a patient before we even got to the shadowing part. And by the time we got there, really what he was showing us was all of the social pieces involved in taking care of a patient, which is public health, in a real sense. But I had no idea that's what it was called, right? And then by the time we got down to seeing patients with him, then he would treat us like medical students way before we ever touched the med school. And so he would let us go in, interview the patient. He'd come back out and he would ask me and Dr. Odom, he'd say, okay, tell me what the mother or what the father told you. How did the interview go? And then tell me what your differential diagnosis is, right? And we didn't know what a differential diagnosis was. I remember the first time he asked me that, I was like, okay, I could tell you what the mom told me, but I don't know what a differential diagnosis is. And he said, okay, well, Dr. Morgan, my maiden name, he was like, a differential diagnosis is after you've talked to the mother, what do you think is going on with the child? And I need at least a list of 3 things that you think is wrong with the child, right? And so he was very good at teaching us that. And then we would go on rounds with him. We would talk to care coordinators with him. So all of this was setting up for a love of public health before I even knew what it was. And then it all started to come to a head when I went to med school and I was the type who really wanted to stay in a room much longer than my attendings wanted me to, because I wanted to talk and get to the root cause of what was really going on with the patient, other than saying, okay, runny nose, cough, fever. Okay, you got this. Here's your medicine. Go. Right. And I remember I had one attending who was family medicine, and they tend to see a lot of elderly people. And I would stay in the room with each patient for like 45 minutes. And finally, I came out of a room and he was like, you can't do family medicine. And I said, well, why not? I really like talking to the people. He was like, no, because you can't stay in a room doing an interview for 45 minutes, Michelle. And I was just like, oh, okay. I said, but they have such good stories. And so it was really that love that kind of drew me to public health before I knew what it was. Concretely, because I know that's what your listeners are wanting, I actually practiced pediatrics for a couple of years. And I always like to say that it was being pregnant with my son that finally tipped me over into public health. So my first year of full-time practice as a pediatrician with Dr. Cheryl, I went back to that group. I was big and pregnant. Second year, I had a new baby. And I laugh at myself now because I thought that because I was so well trained in pediatrics, that this motherhood thing was just going to be a piece of cake, right? And boy, was I wrong. So I had that new baby and I was every bit a first time mother with some pediatric knowledge, but every bit a first time mother. And I realized really quickly that even though I loved pediatrics, I was going to have to make a decision on whether I could be a really good mother to him or be a really good pediatrician. And some people can do both. And I recognized early on that I couldn't. And so I had an attending who actually came by. She was enrolling patients for a study. She was a pediatrician, but she was very much into public health too. And I'm wolfing down my lunch, getting ready for the afternoon patients. I remember stopping and asking her, I was like, how do I get to do what you're doing? Because, see, I'm rushing to eat lunch so I can go see another list of patients. you're leisurely driving around the city, enrolling patients in a study and having a wonderful conversation with me. How do I get to do what you do? And she said, actually, Michelle, I am getting ready to take over a program at the University of Tennessee that trains primary care physicians to be community-based researchers. And she said, sounds like you need to think about applying to the program. And I said, oh, okay, sign me up. Send me the application, sign me up. So I applied. I got in. And it was cool because I was able to start working part-time as a pediatrician. The program that I got accepted to at University of Tennessee paid for my degree, my first public health degree, a master's in epidemiology. And it also paid the other half of the salary that I would have had if I was working as a pediatrician full time. So I had absolutely no excuse not
Right.
to go back to school. Like I needed to go back because they were covering my full salary. I was a full-time student, no bills there. They were paying for school. And I fell in love with public health at that point.
I love that. All the details, because first of all, I love that you got that exposure early on, that entire process. I feel like every medical professional going through training, every medical student, resident should have that experience. It really does make
It
for a
makes a
whole different.
difference
Mhm.
because we know medical school is very tailored, right? So you have a couple of years where you're just getting bombarded with information. You got a couple of years where you're trying to figure out what you like the best, working in the hospital, doing your clinicals. And then you choose what you want. But then once you go to residency, you're getting trained to do very specific things, which is nothing wrong with that. That's how allopathic medicine is set up. But for those folks who may want to have a little bit of difference in their days, in their career, it doesn't always go together. And
Mhm.
so I'm like you. I feel like medical school curriculum should include that public health piece just to let physicians, nurses, other providers know that there are options that you can use your traditional training to build on.
Love that. That's a great story. That's wonderful to hear. And then that personal piece, sometimes you're inspired by your personal choice. And kudos to you for recognizing that I have to do one or the other, but I'm not one of those people can do both of those well.
Well, I mean, I was a little hard-headed now. Like, I didn't tell the whole story because I know we only have so much time. But after I finished that master's, I was married at the time, and my husband at the time was getting ready to do a radiology fellowship at Johns Hopkins. And one of my professors at UT overheard me saying, hey, I don't want to just go back into the clinic to go back to what I was doing. I want to use all this new epidemiology knowledge I have. And I got to figure out what I'm going to do because I'm getting ready to move to Baltimore for 2 years. Right. And so she pulled me aside and she said, no, Michelle, you're really good at this public health thing. And the best public health school in the world is in Baltimore. It's like, Johns Hopkins? She was like, yeah. And she said, you should apply to do a doctorate in public health at Johns Hopkins. Now imagine how I looked at her because I've already done med school,
Uh-huh.
residency, and 2 extra years of school I was not planning on. And now she's telling me to go back to school.
We would have had words.
And I was like, well, how long is that going to take? And then this is the part of the story that she lied to me a bit, but it was good. It was helpful. She's like, oh, don't worry about that. They'll probably let you transfer some credits. Like, just go to the open house, visit it, see how you like it. I did what she said, and I fell in love with it. I applied. I got in. I got a special scholarship. I was like in the second cohort of the Brown Urban Health Scholarship, paid for by a family in Maryland who was interested in increasing African Americans and other BIPOC people having PhDs in public health. And so my chair of my department calls me and I'm practicing still, right? And he was a pediatrician formerly too. So he calls, he's like, Michelle, what are you doing? Right? Because he could see my application. He knows that I'm a pediatrician. I said, oh, well, I'm seeing patients. He said, well, can you take a break? I said, sure. He said, okay, I want you to take a break. Go to your office. So I go, I sit down. And he says, this is the best part of my job. I not only get to tell you that you got into Johns Hopkins, into a doctoral program for public health. He said, but I could tell you that we're going to pay for everything. We're paying for everything. You're going to have a living stipend. You're going to have so much money to do research. And are you ready to come? And I was just floored. Like, I was just like, okay, apparently I'm supposed to be going back to school again. I ended up doing it. He did know what I was going to do. He knew it. He said, now, Michelle, when you get here, you're going to be a full-time student. You cannot be working like you're working right now. You could do that with your master's degree. You cannot do that with this program. And I said, oh, okay. Tried to work in that urgent care in Maryland for like the first month I was in school and failed my first two exams, my first FE exam and my first biostats exam. And I came home and I told my husband at the time, I said, I can't work. He told me I couldn't do it. He was right. I can't work. I have to just go and be a full-time student. And I didn't look back after that. I recovered from those two Fs and
Very humbling, right?
I did not look back. And it was one of the best decisions I've made in my entire life. Yes, I took a pay cut. Yes. Yes, I became a full-time student again, but I would not trade that experience for anything.
Well, that explains a lot. Whenever I see someone who has 2 terminal degrees,
Yes.
I'm like, start shaking a little bit. Like, I can't imagine that having gone through to get the master's and then the PhD, and I just can't imagine doing another terminal degree. But kudos to people who can. And thank you for sharing that story too, because that's very real and very relatable too. And it really does explain a lot of kind of what I think of as like superpower, because you do have these different perspectives and angles together that position you and sort of prepare you for exactly the type of work that you're doing. Very uniquely prepared. So I love the stories. I have to make sure I
I
stay
have
on.
lots of them, so I'm trying to cut it down so I don't take up
No,
all your time.
no, I know my listeners love the stories. They really do. I get that a lot because these are the types of conversations that people wish they could have with folks like you, but they really can't, especially if you're kind of passing in a busy time. So I know they really appreciate the stories. I get that type of feedback. Okay, so here's my next question for you. And this is really great kind of lead up to it. Given the diverse background and the experiences that you've had, is there a population or condition or a specific challenge that you're most passionate about addressing or serving at this time?
Oh, wow. What a great question. So, for me, especially coming home to be director, it really has given me a chance to educate my hometown, this population, this group of people who have chosen to make Memphis and Shelby County their home on what it really means to talk about health equity, health disparities, the difference between the two terms, what the context of this place means to how we address health outcomes. It's given me an opportunity to really educate the population. I think that for the last actually at least 5 to 10 years, at least 5, health equity has become a buzzword, but the common everyday person doesn't really understand what that means. And so when you don't understand what something means, then it means that certain people can come and twist the meaning of that to make it mean something else. And so I've been very fortunate to be in a place where I know the population well. I grew up here. In Memphis, Memphis is the kind of place that people ask where you went to high school and where your parents went to high school, and it gives them like an immediate pedigree of your family. It's not always 100%, but they kind of know, right?
Hmm.
They know where you went to school, how you were educated, how you were raised, all of those things, right? And so it's been an opportunity to bring diverse groups together here around a common cause, which is everybody wants to be able to reach their optimal health. No matter what station in life you're in, everybody wants that opportunity. Let me tell you the history of this place that has prevented some from reaching that optimal health and why. And let me explain to you no matter what disease condition we're talking about, no matter what service we're talking about providing, explain to you why it's important for that service to exist and why it helps everybody, no matter who you are. So really, that's what I'm most passionate about is explaining to populations. Listen, you can say all day long, well, I don't have any reason to go to the health department. But it's been so fun to prove to people that that's just not true. Sure, you may not be coming here to pick up a car seat. I didn't get my car seat from the health department. But I bet you have to come in here to get either a birth certificate or a death certificate. You may be coming in here to seek services around tobacco cessation. Or you may just be benefiting from a report on the news, because local news is king here, around how to protect yourself from measles. And so we always here at the health department, we as a group, and we have about 550 employees, we're always telling people we are a health department for everyone. No matter who you are, you can walk into the health department and get the services that you're seeking if we provide them.
Mm-hmm.
It's an equal opportunity type of place. And so that is what I'm most passionate about, that populations need to know public health, while invisible, really does a lot of important work that means that you can reach your optimal health. But you got to listen and you got to be willing to come into the circle and the fold. And even if you're not willing, you're there, whether you know it or not.
Yeah. That so aligns with my views and what I say quite often, and why I even focus so much on like communicating epidemiology in plain language when I use phrases like that.
Right.
Because, like you said, educating people hear certain phrases but don't really understand what they mean. Like you said, there's too much room for the misinterpretation and miscommunication, the false information. So that's a great way. I like the way you just described that. I can imagine, and this is probably a good time to bring this up because, we were talking about this also before we started to record. I knew it would naturally come up, but at the time that we're recording this, and I'm going to put into context because I know people will listen to episodes, they'll listen to ones from a couple of years ago. And so in a couple of years from now, when someone's stumbling across this episode, I want to put into context, this is the spring of 2025. We're a couple of months into this new presidential administration with President Trump. And as a public health professionals, as a group, as an industry, we feel very much like we're being ripped apart, dismantled. And a lot of times I keep hearing phrases erased. It feels very much like that. We're all, we try to prepare ourselves for what it might be like. But everyone that I speak to is like, we had no idea it would be like this. There was no way to really prepare for something at this level. So I just am wondering, again, as we're talking about what you're passionate about and what you're describing, with the shifts in this administration, because this is exactly what you just described. There's a lot of chaos and a lot of confusion. And in situations where people don't understand what health equity means or, DEI initiatives, diversity, equity, and inclusion. I mean, people have their own definitions or understanding what that means. And now they're hearing so much flying around that there is just, I hear some real true garbage. I don't even know how to describe it. So I imagine that presents a special challenge for you, unique challenge for you. But I guess what are some of the challenges around that as it relates to, you leading a very large department, group of people, area, county, and with a mixture of people? And how are you kind of navigating this?
Yes. So right now, within the last 2 weeks, we're at a point where we've had to lay off about 11 staff members with more anticipated. We are actively thinking about litigation, but here's the rub. So at this moment in time, because like you said, some people are going to listen to this in a couple of years. At this moment in time, there is a restraining order, a temporary restraining order for about 27 states that have asked for their funds back that were cut from HHS, HRSA, and CDC, right?
Mm-hmm.
But, Shelby County Health Department is a blue dot in a red state. So our state is not a part of that TRO because we weren't a part of the lawsuit. for obvious
Right.
reasons.
Right.
And so it is always interesting, and it has always been interesting to lead this department from a blue county in a red state. With that said, I have learned more about figuring out how to bring the public health message in a red state and get the things done that we need to get done, even when the ideology of this particular local population may not match up with what's going on in the state house. And we've had great successes, not only rebranding ourselves after a really rough COVID period, right? But also with figuring out how to have the best working relationship we possibly can with our state health department, and always bringing it home to we're concerned about public health. We're not going to play politics with the rest. We're concerned about public health, protecting lives, protecting health, protecting our people. And, I think it hasn't completely insulated us from the chaos, but I would say that even when we have people in our own county that don't agree with everything the health department does, they do respect that at the end of the day, they know that we're trying to promote health and save lives. So, a concrete example of that is when we were still in COVID, we were one of the only counties in the state that was still masking in schools because the kids were being told they had to go back. State mandated that. And we had to come up, and we had the largest school system in the state, 24th largest in the nation, over 100,000 students. And so we had to figure out a way to protect these students, even though our vaccine rates in Shelby County were lower than in some other places. And so we were able to do that. We were able to show great protection until the state took away our ability to mask. So they did take that away eventually, but we were able to do that. And I'll never forget, I had a call. So we have 7 municipalities in Shelby County. Memphis is the largest, but there are 6 others. And every municipality has their own school system. So as a Shelby County Health Department, we were able to say masking has to occur across the board in all the schools. And then when that was taken away, each school system could decide for themselves whether they wanted to mask. So, of course, our large school system in Memphis Shelby County Schools decided they were going to continue to mask. But a lot of our smaller municipalities decided they would not do that, which was their right. So I remember from one of the smaller municipalities, I got a call because we used to have a every Friday call with schools, mayors from the area, all of that. And Memphis Shelby County Schools reported a COVID rate that was much lower than some of the rates for the other smaller municipality schools. So I got a call from one of the superintendents, and he said, "Well, Dr. Taylor, I really don't agree with the data that I heard today on the call." I said, "Well, tell me more. What's going on?" And he said, "Well, there's no way with the number of students that they have in Memphis Shelby County schools that they have a lower COVID infection rate among their students than we do among our students. There's no way. That could not be." And I said, "Okay, well," I said, "that is possible because they're reporting it as a rate." I said, "Now, raw numbers may be different, but as a rate, that's possible." He said, "That couldn't be. They got too many kids. They must be undercounting." I said, "Let me ask you this." I said, "Because I already know the answer, but I'm going to ask you this." I said, "You need to understand that Memphis Shelby County Schools chose to continue to mask. I know that you all chose not to. And you are probably the reason why we got masking enforcement taken away from us at state level anyway. You all were complaining about that." I said, "But that's neither here nor there." I said, "But I promise you, if I came out east, because other municipalities are east," I said, "if I came out east of the county and I walked into any store, out of 10 people who get the choice to mask or not, I might see 1 or 2 masks. And there'll be a third because I'll have my mask on." I said, "But if I go west in the county And I walk in the grocery store over there. I said, a lot of those people may not be vaccinated, but I guarantee you they got a mask on. I said, so I understand that your vaccination rates are higher in the east part of the county, but your masking rates are not. And so we'll have to agree to disagree on the data around who has a better COVID infection rate at their schools. I know he was frustrated with me, but I was just like, we can argue about methods, like how you should tackle this problem, but you cannot argue with the science, and even within COVID briefings, because I had to do those once a week, I would show when I knew they were about to change the masking law. We would show kids between the ages of 5 and 12 in all of the other metropolitan areas in the state of Tennessee. All of them had higher vaccination rates than us, but all of them also had higher COVID infection rates than us. And I believe that we can't totally attribute it to the fact that we were masking, but a lot of it had to do with it and how we were teaching people every day how to protect themselves and their families and their children and the community.
So I love your story. And I'm listening to you and I'm thinking, okay, Shelby County is a blue dot in a red state, but that's a county. So in my state, I am literally the blue dot, not like the county, the person in this red state.
I understand.
So I really started sometimes I could feel like, well, I try because it feels overwhelming. But lately I really started to shift that. And I've started to, some people tell me I'm just disillusioned, but I do feel like I'm kind of hearing my colleagues saying, it matters, your voice matters. And I'm listening to what my constituents or my representatives are saying, that they want to hear from us and they want to have these bipartisan conversations. So I keep, showing up and keep attempting and, listening to you and thinking about this. I want to hear from you. Am I disillusioned? Should I keep trying this? Is this going to make a difference?
I think you should definitely keep trying. I think we're in a moment now where you're not going to convince everybody. You're just not, but that doesn't mean we stop trying. I think one of the responsibilities of public health is if we find that the message isn't hitting or we're not doing a good job of explaining why we're so passionate about certain subjects, then it means that we need to shift as a public health workforce in how we're messaging. And we need to remember, this is an old adage, but really we need to know our audience, right? We need to get to know our audience because at the root of it, and I may be naive in thinking this, but at the root of it, most people want their families to be healthy, to be prosperous, to be able to live their lives and reach the optimal health that they feel that they deserve to reach. Most people to a person want that, right? For themselves and their families. But we may not always agree on how to get there. But if we're not talking to the people that we don't agree with on how to get there, then they will get that information. And a lot of times it's misinformation from someone else. So what are we doing to kind of cut through the chaos, right? To kind of take that bite of the elephant one, bite at a time.
That's right.
And figure out where we're missing the mark on our messaging. We're not always missing the mark. That's not what I'm saying. Because I know some people will be like, but we can't just erase. No, that's not it. And we're not selling out. But what we are doing is saying that, okay, I'm going to at least listen to your point of view. I'm going to at least try not to have a judgmental face, right? Some people, you can be judgy in your mind. I wouldn't recommend it, but you got to control your face, right? And then you have a conversation like a regular person, right? And just get to the root of what people are feeling. What makes you happy? What makes you sad? What are you really wanting for your family for generations to come? That's where you start to get to the crux of the issue.
That's very reassuring and confirming for me. And I appreciate you in your story, especially here. So if nobody else is getting anything from this is really good for me because it does really help me sift out the politics and continually refocus on the health. And it's about public health and really leading with that message and helping people to, kind of turn the light on for people about what public health means and insert any other topic that, is on the table at the time, but continuing to show up in places where we can have conversations where
That's right.
if I'm going to sit and listen to what they have to say, then they're going to reciprocate and then listen to what I have to say. That is true definition of a conversation. So it feels very confirming, reassuring to hear you say that because I was leading that direction, feeling very solo. Like I said, the true blue dot individual, but I will continue on. Okay, I'm enjoying this so much. I was like, time is getting away from us. I'm going to try to wrap this up and maybe one more question. We're going to skip down to a bit of advice because, I took that one for myself and very selfishly, and I'm not going to apologize. But just thinking about listeners, because we do have a lot of people listening from all stages, students, professionals of all levels who are just stunned, and we're all trying to figure out what to do. Is there any bit of advice, any general bit of advice or anything else that you would share for people who are trying to figure out what to do in all of this?
So my biggest advice right now is don't panic, right? So my former deputy would always say, he's like, I love your military bearing, right? He's like, I know that you could be screaming in your head, but we will never know, right? And that's a thing. Don't panic. Yes, there is a lot of chaos. There are a lot of bad things happening, but we also understand that there is work to be done. So if you find that you're in a position where you're getting a pink slip and it says that you can't do work at this organization or this place where you've been doing it, there are other places where you can get that work done. Because at the end of the day, the work is still there. And the work is being recognized and the work is being fought for by so many sectors right now. There are so many people who are making connections. Every day we'll get one report about something being cut, but what else do you get? You get another report about, no, they're going to add this back in because this shouldn't have been cut.
Right, right.
That shows you the power of saying, you know what, no matter what we have, no matter if we go from 200 to 2, no, it's not right that that happens. Shouldn't happen. But the work still has to get done. So it's really about figuring out how you work with your teams, how you work with your coworkers, how you work with people who are working in the space to figure out how you get the work done, no matter what the noise is around you. Figure out how you keep that bearing and keep serving the people that we know need these services, need these resources, need this help, because it really is everybody, depending on what part of public health you're in. Figuring out how the work still gets done. And then when you know the work has stopped, figuring out how to get that story out there to help people to understand what the ramifications are of work getting stopped.
Thank you so much.
Absolutely.
I've thoroughly enjoyed our conversation. And thank you for being so generous with your stories and your time and insights. I appreciate you so much.
It's been a blessing. I'm glad we were finally able to get this done. I'm looking forward to seeing the final product. And I hope that it will help. I hope that my experience will help somebody else to stay in the public health fight because we need everybody.
Yes, I'm convinced that you're both inspiring, insightful. I know it's going to help more. So thank you.
Thank you.
I really hope you enjoyed that conversation as much as we did. Dr. Taylor is a true heart-centered leader and innovator and is having a big positive impact on the communities that she serves. I really appreciate her vulnerability, her willingness to just peel back the shield and relax into the conversation and share with all of you so generously. I've really enjoyed getting to know her. This episode has been a long time making because We've crossed paths multiple times. We've tried to work on this. We bump into each other a year later, and it's like, oh, we haven't done that yet. And about 6 months ago, we decided we were going to make this happen, and we did. So I'm so excited and grateful that she shared so generously with us on this episode and that we're able to finally put this together and share it with all of you. I encourage you to connect with her and learn more about the work that she's doing, and be sure to let her know that you heard her episode on this podcast. You can find the link to connect with her on the show notes page. The show notes page for this episode, which is episode 404, can be found at phecpodcast.com. Once you're there, just navigate to episode 404 to find its show notes. Now, one more thing before you go. Remember to download our new PHEC Podcast Community app in Apple and Google Play Store. You can also visit phecpodcastcommunity.com to join the community on desktop. All of those links are in the description for this episode, but I needed to mention that to you. All right, everyone. Until next time, have a fantastic rest of your day. Thank you for listening to the Public Health Epidemiology Conversations podcast. Visit phecpodcast.com to find the show notes for each episode and to learn how to work with me.